So before we delve into this particular topic, it is important for you to know that intestinal problems can lead to inadequate absorption of essential nutrients and affect the need for nutrition as well as elimination. Now, if these disorders become severe, comfort and/or cellular regulation alterations and problems, of course, with fluid and electrolyte balance can occur. And this is all a part of your normal anatomy and physiology, of course. So intestinal health concerns are categorized as inflammatory or non-inflammatory. But this discussion, of course, will focus on non-inflammatory conditions. At the end of this lecture, students will be able to collaborate with the interprofessional team to protect the patient with non-inflammatory intestinal disorders from injury and infection, identify community resources to ensure appropriate transition management for patients with a non-inflammatory intestinal disorder, teach adults health promotion practices to prevent non-inflammatory intestinal disorders, and also to teach patients with a colostomy about self-care management. Now, irritable bowel disease can also, or is known as spastic colon, mucus colon, or also nervous colon. This condition is very common, and it does affect about 20% of people in the United States. What happens is there is bowel motility changes, and so there is an increase or decrease in bowel transition times that results in changes in normal bowel elimination patterns. Now, they classify them into 4 different groups. That's IBS-D, IBS-C, IBS-A, or IBS-M. So your patients can have any of these specific or categories of this condition. This typically occurs in young adults, and it lasts throughout their lifetime, unfortunately. As far as causes or etiology, it has a combination of environmental, immune, genetic, hormonal, stress, in particular anxiety, and also want you to see examples such as environmental issues. You want to think about foods and fluids like caffeinated and carbonated drinks and dairy products. See also immune and genetic and hormonal, as well as stress specifics in your reading. Women do acquire this condition more than men, and the long-term nature of dealing with such a chronic disorder without a cure leads to a kind of secondary depression. So these patients should be screened for depression. So let us go ahead and get into some assessment findings for irritable bowel disease or syndrome. As far as questions you want to ask these patients in terms of their history, you do want to know if there has been a weight change, if they have been fatigued, if they're experiencing malaise, abdominal pain, constipation or diarrhea, or both, etc. Patients with IBS, they pretty much do not lose weight. And also, as far as you also want to ask them about if they're taking any medications. That is important to know as well. Ask about if they're drinking any caffeinated drinks, as well as beverages sweetened with sorbitol and fructose, because this does lead to bloating as well as diarrhea. Now, the course of the illness is individualized to each patient. For example, with some patients, food intolerance can be issues with dairy products. In other words, lactose intolerance. Also, raw fruits, grains can also contribute to bloating, also flatulence or abdominal distension. Flare-ups typically consist of worsening abdominal cramps, abdominal pain, and again, these patients may have a combination of diarrhea and constipation. We also want to encourage these patients to keep a food diary to record possible triggers that may cause their IBS to flare up, cause their signs and symptoms to come about. The most common concern for patients with IBS is that they have pain in the left lower quadrant of the abdomen. There's also internal visceral or organ hypersensitivity can contribute to pain issues as well. Now, nausea is associated with mealtime and defecation. Constipated stools are small, and diarrhea, of course, stools are soft and watery and also contains mucus. And there may be some belching, gas, anorexia, and bloating as well. As I mentioned before, these patients usually do not lose weight with IBS. And another thing of note is that their fluid and electrolytes are within normal limits. And this is probably because they're just not having a whole lot of diarrhea, but they have, again, a little of both constipation and diarrhea. Now, also remember, patients who are constipated, they will usually have hypoactive bowel sounds, but with diarrhea, the bowel sounds will be hyperactive. And of course, when you listen to these patients with your stethoscope, you're auscultating for either one, in other words. As far as routine lab values, they are usually within normal limits for patients with IBS. Now, your physician might use the hydrogen breath test or a small bowel bacterial overgrowth breath test. And what I would like for you to do is read any additional information on this test on page 1136. So let us go ahead and get into some of the interventions for irritable bowel disease. Some of the interventions will include health teachings, drug therapy, and also stress reduction. Now, dietary fiber and bulk does help produce bulky, soft stools and establish regular bowel elimination habits. These patients should consume 30 to 40 30 to 40 grams of fiber each day. And they should also, or you should teach them to also drink 8 to 10 glasses of water each day. And they should also be instructed to chew their food slowly, and this does help promote normal bowel functioning. Drugs normally prescribed are the bulk forming agents as well as the antidiarrheals. Now, I spoke to you earlier about the different types of IBS. You have the A and the C, and I can't remember some of the rest of them at the moment, but for this particular section, we will talk about IBS-C, and this one is treated with Metamucil and lubiprostone for women with this condition. And what this does is it increases fluid in the intestine to promote bowel elimination. Remember, the more fluid you have in your bowels, the better or the easier elimination will be. There's another drug that is pretty much one of the new ones that a lot of women seem to be using is Linzess. And it is used to treat this same IBS-C condition. What this does is it stimulates receptors in the intestine to increase fluid and promote bowel transit time. It also helps relieve pain and cramping associated with IBS. Now, there's also an IBS-D, and this one is treated with antidiarrheals like Imodium, silicium, and also alocetrone. The latter drug that I just mentioned, you want to make sure you use with care because patients with signs and symptoms of colitis and or constipation is associated with potentially life-threatening bowel complications. So must be reported, it must be taught to these patients rather that they should report their signs and symptoms very early to avoid this complication. Now, patients with IBS who also has bloating and abdominal distension, but without constipation are treated with rifaximin. And these are actually spelled out for you in the presentation notes section, so you don't have to worry if I even kind of mess these words up a bit. Also, Elavil has been used to treat IBS pain as well. And of course, this is when we get into these different pathways like your neuropathic type of pains and whatnot. They're treated with the drugs such as your Elavil, your gabapentin, and your dilantins. But in this particular case, Elavil is also used for the IBS pain. And also keep in mind that some patients will also use the complementary and integrated health therapies as well. Nothing wrong with that. So I'd like to talk to you about hemorrhoids. This is another topic that we have to discuss. Hemorrhoids are swollen or distended veins in the anorectal region. Veins involved in hemorrhoids are part of the normal structure in the anal region as well. As far as a pathophysiology, I'll make this a little short just by telling you that there's increased pressure that comes from areas such as the abdomen. We refer to it as intra-abdominal pressure. And these essentially cause an increase in the amount of pressure in the vasculature in the anal region. And of course, when these patients have an increase in pressure in that area, it ultimately results in these distended veins, because that's pretty much all hemorrhoids really are. It's distended veins. Let's see, so I gave you an abbreviated version, but just go ahead and read the other additional information that I placed here in the notes section. Now, hemorrhoids can be internal, which means that they cannot be seen on a visual inspection of the perineal area. So essentially, these, well, your physician, he would actually have to use a scope. Sometimes they, I believe it's called a proctoscope, where they can actually, or maybe an anal scope, they're able to actually visualize internal hemorrhoids. Now, you also have external hemorrhoids, and they can be seen on just inspecting the anal region, because they're on the outside of the sphincter muscle. Now, we have what is also called prolapsed hemorrhoids. They can be thrombosed or inflamed, or they can also bleed. Now, hemorrhoids really does not become an issue unless they become extremely painful or you're getting some significant bleeding as well. Now, as far as the increased abdominal pressure that I mentioned, there are certain conditions that a patient may have that could actually increase the intra-abdominal pressure, hence increasing risk of hemorrhoids. And those would be patients who are pregnant, people who are constipated from sitting, constipated from straining, also patients who are obese, who have heart failure, people who sit for a prolonged period of time, as well as standing for a long time. Patients who participate in strenuous exercise and weightlifting can also be subject to hemorrhoids. And also, if you have someone who takes a decreased amount of fluids, can lead to hemorrhoids because of the fact that when you don't have enough fluids on board, your stools tend to be much harder, in other words, constipated. And of course, when these patients begin to strain, then that can lead to hemorrhoids or worsen hemorrhoid condition. So let's go ahead and get into some of the interventions for these patients with hemorrhoids. The most common signs and symptoms of hemorrhoids are bleeding, swelling, and also prolapsed veins or bulging of those anal vessels, blood vessels. Blood is usually bright red, or we may abbreviate it as BRB, or bright red blood. You see that written in some of your notes, doctor's notes, or their progress notes. Also, there may be a streak of blood on toilet paper, or also in the stool, the patient's feces. This pain is actually associated with thrombosis. There's also itching and mucus discharge associated with hemorrhoids as well. Diagnosis can usually be made by inspection, as I mentioned before, or digital exam. As far as the interventions are concerned, treatment usually is conservative, and that is to reduce signs and symptoms, and also to minimize discomfort. Now, cold packs can be applied to the anorectal region, and this helps to reduce pain. Also, these patients may be advised to take tepid baths 3 or 4 times per day, even if they have this thrombosed condition of their blood vessels, and this can provide some relief as well. For pain and or itching, drugs such as lidocaine and ibuprofen can also be provided to give relief. Steroids can be prescribed for inflammation as well as itching. To avoid anal irritation, cleansing of the area with a moistened cleansing tissue versus the standard tissue should be employed. And you want to ensure or instruct these patients to dab as they dry themselves, not wipe, but to dab, because wiping could actually cause increased discomfort. So make sure they're dabbing. We also want to promote a diet high in fiber and fluids, which can promote regular bowel movements without straining. The physician may also prescribe stool softeners such as Colace and Marilox, and this is actually more on a temporary basis. Now, irritating laxatives and food and drinks are to be avoided, as they can make hemorrhoids worse. Irritating foods such as spicy foods, nuts, coffee, as well as alcohol. We have to also discourage these patients from sitting for too long. As far as conservative treatment, which I just mentioned, this condition can heal within about 3 to 5 days, but of course, your book didn't seem to talk about a recurrence, and there is some reoccurrence, I promise you. Signs and symptoms occur frequently, or reoccurrence might result in the patient needing surgery. So I guess in a sense they do talk about it, but I guess I was thinking about something else. Um, anyway, so yes, it can happen frequently, most likely happens frequently. Most patients don't seem to have a surgery, but depending on the severity of the condition, you might need surgery. These patients who um, these patients who do have a hemorrhoidectomy um, is actually done in the outpatient setting. Um, Now, complications from this surgery is pain, thrombosis of other hemorrhoids, as well as infection, etc. So there's some additional information for you to read. We must also teach these patients again about a diet high in fiber and fluids to promote bowel movements before surgery. And again, we want to teach them about the sitz bath or warm compresses about 3 to 4 times a day to promote comfort. These patients, they will be started on stool softeners before surgery as well as after surgery. A mild laxative is prescribed if no bowel movement is done by the third post-op day. When they have a hemorrhoidectomy, you want to make sure that either the nurse, if he's in the hospital, or if he's at home, that someone is always there with him, especially for the first one, because the pain is strong enough to induce a syncope. It's just that bad. So you just want someone to stand by for safety reasons in case the patient possibly falls and injures themselves. I think that's about it here.